Part 3, and this we're starting with the special types of acute cholecystitis. Yesterday we had talked about day before yesterday, I think, or 2 days back, we had talked about the acute cholecystitis, the management. Now we'll talk about some variants of acute cholecystitis, and the first variant is the acute acalculous cholecystitis, and you have 5 to 10% of all acute cholecystitis being accounted by the acute acalculous cholecystitis. And if you look at the number of cholecystectomies being done for acalculous cholecystitis, there will be numbering somewhere in the region of 1 to 2%. Now, this is basically what we mean by acalculous. It's a non-calculous obstruction of the cystic duct, and more commonly it is probably because of the edema of the cystic duct. The infection is usually bloodborne and associated with a higher incidence of gangrene perforation as compared to the calculous cholecystitis. So, in a way, this is a much more dangerous kind of cholecystitis that we are looking at, right? It's got more serious morbidity, higher mortality rates than calculus, and look at the mortality rate. For acalculous cholecystitis, it's varying somewhere in the region of 10%, 50% almost, as compared to 1% for a calculous cholecystitis, right? Now, if you look at the pathophysiology of this condition, acalculous cholecystitis, the starting point is the bile spaces and increased lithogenicity of the bile. And that's usually observed in very ill patients, like, for example, a patient with mechanical ventilation, a patient who's got septic problems, a patient who's got severe burn injury, or after severe trauma. And all these conditions, because of dehydration and decreased contractibility, there's an increased bile viscosity, the fever and the dehydration, right? And also because of prolonged absence of oral feed, because these patients will be more likely on intravenous fluid, they'll be on mechanical ventilation. So because of decreased oral feeding, there's a decrease of absent cholecystokinin-induced gallbladder contraction. The gallbladder doesn't contract. So viscosity, along with the fact that the gallbladder doesn't contract. And together with this, because of low flow state, there's some degree of gallbladder wall ischemia, and that is because of the hypovolemia in a particular patient, the dehydration in a particular patient. So these are the group of patients which are more likely to be involved in a disease which we now know as acalculous cholecystitis. More susceptible patients, more patients like, for example, a patient on total parenteral nutrition, those with cardiovascular diseases, patient with diabetes occasionally, patient got a gallbladder dysmotility, or conditions has been reported also in hepatitis A in a pregnant female, or acquired immunodeficiency syndrome or cholangiopathy, right? Now, if you look at the diagnostic criteria, diagnosis simply just like in acute cholecystitis, we're looking at an ultrasound, we're looking at a CT scan, and the preoperative diagnosis in the ultrasound would be that you don't find any stone. Instead, what you find a thick gallbladder wall and less than 50% reduction in size after fatty knee. Remember, when we're talking about the dyskinesia, we said anything less than 50%, somewhere in the region of 35 to 40%. It's less than that, it's probably some kind of dyskinesia. Similarly, out here in the acalculous cholecystitis, looking at a reduction of gallbladder contraction, somewhere in the region of less than 50%. It could also occur like a chronic, and this is basically what we last time talked about, biliary dyskinesia. That's why, are some of them biliary dyskinesia? We still don't know. So this patient would be presenting with recurrent biliary pain, and all investigation would be normal in this particular patient, right? Now, coming to the second variant, that's the Botkin's biliary cardiac syndrome. Now, this may appear to be very bombastic kind of a terminology, but just to make you understand, this is basically some kind of risk involved as compared to the cardiovascular and the biliary. So there's some kind of relationship. This relationship is complex and reciprocal. Acute cholecystitis and cardiovascular disorder. So it works both ways. Cardiovascular disease is a recognized risk factor for developing acute cholecystitis, and gallstone disease is an increase in the risk factor of cardiovascular disorder, right? Like, for example, stroke, coronary artery disease, and cardiac failure. Now, among these two are very common. One is the polycystic pericardial syndrome, other syncopal cardiac syndrome, seen 1.78 and 1.33% respectively, right? So these are some kind of diseases which would be there coexistent with acute cholecystitis. Now, what is the importance of this? Now, often what happens is that you get a ECG done in a patient as a pre-operative workup in acute cholecystitis. You want to operate on this patient, and what are you doing? The anesthetist advisor, oh, now you know that I have to get an ECG done. In that, you get some kind of abnormality, and you say that this is probably because of acute cholecystitis. But why because of acute cholecystitis? The reason is simple, that there's some kind of a relationship, inverse relationship, or a direct relationship between acute cholecystitis and coronary artery disease. So next time, don't just brush away a minimal or a minor alteration in the ECG in a patient who has probably got some kind of a cardiac problem related to acute cholecystitis, right? And if you look at the cholangitis, not only acute cholecystitis, primary biliary cholangitis, even that is treated with cardiovascular problems. Cardiac involvement as much as 4% of cases. And they're more frequently males that you have the involvement in. Complicated with inflammatory myopathy. So these patients likely be having cardiomyopathy and had a longer disease course. Furthermore, you have inflammatory myopathy, which is a strong independent risk factor of cardiac involvement in primary biliary cholangitis, right? So just remember next time when you're talking about a patient with acute cholecystitis showing some kind of abnormality in the ECG, you have to be sure that this patient doesn't have a co-existing cardiac problem. The third one is emphysematous cholecystitis, which is not an unknown entity, more common in males, older age group, and probably more common in diabetes mellitus. Is a highly virulent and unusual variant of acute cholecystitis. Unusual and highly virulent. Both the things are important. It is unusual, but it's very highly virulent. And as a result of what? Gas produced by infecting bacteria. Most commonly, Clostridium, which accumulates, the gas accumulates in the gallbladder lumen, and then it goes through the wall and leads to pericholecystic collection. So it will involve the lumen, it can involve the wall, and through the wall it can go and involve the pericholecystic area. And several symptoms of emphysematous cholecystitis, they've been used to describe the clinical entity. You've got a number of synonyms, like for example, acute gastric cholecystitis, pneumocholecystitis, gas gangrene, etc., etc. So these are just synonymous terms. If you say any one of them, you'll be meaning emphysematous cholecystitis. Now, unlike acute cholecystitis associated with cystic duct obstruction, in emphysematous cholecystitis is believed to be secondary to ischemia. So you don't find any kind of primary obstruction. In a calculous cholecystitis, what do you understand? You understand there's some kind of a block at the region of the neck or the cystic duct. Here it is not the primary event. What is the primary event? Is infection with or without obstruction. So it is a infection leading to ischemia with superimposed bacterial invasion. So that is the pathophysiology in emphysematous cholecystitis, not a block as the primary event. Here it is ischemia and with superimposed bacterial infection, ultimately leading to a emphysematous cholecystitis. Preoperative diagnosis is easy. I wouldn't say easy, but it can clearly be made out. If you remember when you're talking about the diagnostic investigations in disease of the gallbladder, we talk about the champagne bottle sign. So here also you'll be seeing what? Pericholecystic gas collection, which is more or less confirmatory for this condition. Coming to the next variety, and that is Xanthogranulomatous cholecystitis. So these are all varieties of acute cholecystitis. Don't forget that, right? Or variants of acute cholecystitis. Now here, Xanthogranulomatous cholecystitis or XCG-GC is incidence is in the region of 0.5 to 13.2. 9% of all cholecystitis, these are Indian figures, and 1.5% of all routine cholecystectomy specimens. So that is the incidence in India. Out of routine cholecystectomy specimens, 1.5% could well be granulomatous, and 9% of all cholecystitis preoperatively could be the diagnosis of XGC. While some studies have reported a male predominance, we agree that probably it does not have a gender predilection. So there are studies which say probably male, but as a whole is taken as male and females may be equally involved. But the significant morbidity is there because the inflammatory process usually extends into the gallbladder wall and adjacent structures. So here also, just like in emphysematous, which was bursting through the walls and then into the pericholecystic area, here it also involves the adjacent structures like the transverse colon or the duodenum. And what is the characteristic of this condition? A focal or diffuse destructive inflammatory process. So see, focal or diffuse, it may involve the whole wall, it may involve a part of the wall. And in addition to this, what else happens? Accumulation of lipid-laden macrophages. These macrophages, along with fibrous tissue infiltration and acute or chronic inflammatory cells. So three things are there. Number one, you'll find lipid-laden macrophages, you'll find fibrous tissue, and you'll find acute and chronic inflammatory cells. And these lipid-laden macrophages, they appear like yellow-brown nodules on naked eye examination. Just yellow nodules studded all over the mucosa and also over the wall. So in the wall, you'll get the hyperattenuated nodules. Inside the mucosa, you'll get the yellow-brown nodules. If you look at the pathogenesis, so this is basically what is happening inside the gallbladder. So why is it happening? The reason why it happens is probably an extravasation of bile into the gallbladder wall, from where rupture of Bronchitancy, Ashov sinuses or by mucous ulceration. So the starting point here also is again a mucous ulceration or a rupture through these sinuses that we know of. And what happens? The bile is now leaking into the wall and from the wall to the pericholecystic area. In this process, this extravasation leads to a inflammatory reaction in the interstitial tissue. And that inflammatory reaction leads to what? This whole event of fibroblastic, macrophage phagocytosis, and they ultimately lead to what we know as a xanthoma cell. So this is basically xanthoma cell talking about. And just let me inform you something. That Xanthogranulomatous is, or a xanthoma is not only a domain of the gallbladder. You can have xanthomas of the kidney, you can have xanthomas of a lot of other organs. So this is not a peculiar disease only to gallbladder. It is a disease where you can find a number of organs being involved. Gallstones may or may not be present. And they're present, they may or may not have a pathogenic role, we still don't know. But what we know is that this is the starting point. So here also, emphysematous, the stone was not the starting point. Similarly, Xanthogranulomatous cholecystitis, the stone is not the starting point. Is that clear? If you look at the macroscopic appearance, you may find a fibrotic gallbladder, but dense adhesions are very common. Very common. And generally mimics a gallbladder cancer, and that is the crux of the problem. The crux of the problem is that you open up a patient of Xanthogranulomatous cholecystitis, or you do a pre-op investigation ultrasound, and the report usually is query carcinoma of the gallbladder. Now you don't know what to do. You choose to go in for laparoscopically examining it, and again you find a large lump or a lump which you find infiltrating everywhere, and again your laparoscopic diagnosis is carcinoma of the gallbladder. That is the problem with this condition. It is not a malignancy, but it can also be associated in a very small group, in a very small percentage with primary adenocarcinoma of the gallbladder. But by and large, it is a non-malignant condition. It can also present acute cholecystitis. That is why we took it as a variant of acute cholecystitis. And the diagnosis usually by ultrasound, but the final diagnosis is always microscopic. And if you see such a large lump, you choose to remove it, it is usually not possible by laparoscopic. It has to be by an open cholecystectomy. Now this is, I just want to show you some figures. See the wall? See the wall out here? See the wall out here? So thick. See this wall. It can easily be mistaken for what? Easily mistaken for a malignancy of the gallbladder, right? Now coming to the next variant, that Mirzi syndrome, which you all know and which we understand, but needs to be repeated here because that's more common among all these that we talked about. This is perhaps more common, and this is basically named by a Argentinian physician by the name of Pablo Mirzi, and refers to what? Just remember this and note it down. It is a obstruction or basically an adhesion or extrinsic compression with the common hepatic duct, and hepatic duct has to be underlined. It is not the common bile duct. Let me repeat again. It is an extrinsic compression formed as a result of adhesions between the wall of the gallbladder in the heart mass area, the cystic duct, to the common hepatic duct, not the common bile duct. Is that clear? So the definition of Mirzi syndrome is an extrinsic compression from an impacted stone in the cystic duct or heart mass pouch to the common hepatic duct. That is the starting point. Inflammation both ways, cholangitis, inflammation of the gallbladder. So it works out and it forms adhesion, and then it develops into the subsequent stages which you just now enumerate. So it occurs in 0.1% of patients with gallstones and 0.7 to 1 to 8% of all cholecystectomies. That clear? So that is the incidence of Mirzi syndrome. And what are the pathogenesis? I just now told you. First is the inflammation and adhesions between the CHD, that's the common hepatic duct, and the heart mass and the cystic duct area. Now what happens? Because of the pressure of the stone which is there in the heart mass pouch, pressure where into the inflamed wall of the gallbladder and the inflamed wall of the CHD. Now what happens? Ischemic necrosis. Now what happens? Ischemic necrosis, the stone tries to burrow from the heart mass pouch into the CHD. And now the CHD becomes attached to the gallbladder at two sides. One is the cystic duct side, that is the normal. But here now develops a fistula into the CHD. So from that area from where the stone has burrowed into the CHD, there is a generation of a fistula. And now what will happen? The stone goes into the CHD. So initially, because of the pressure of the stone in the heart mass pouch and extrinsic compression of CHD, there was a mild degree of obstructive jaundice. It is only pressure. But now when the stone goes into the CHD, there is a full-blown obstructive jaundice. And it just behaves like a choledocholithiasis. where the stone is now lying inside the CHD. So initially external compression, and then later on when the stone goes in, it is an intraluminal blood. Mersey syndrome, remember, again is a pre-malignant condition, right? Xanthogranulomatous cholecystitis was a pre-malignant condition. Mersey syndrome is a pre-malignant condition, and you find 5 to 28% of patients with Mersey syndrome after cholecystectomy, you find them to be a malignant alteration in these patients. 28 is a very high percentage. Probably we may not agree with 28. That was given in the literature, but 5 to 10% should be a more realistic figure of these patients with Mersey syndrome who can manifest with malignancy, right? And I said earlier, virtually all diagnoses are made per-operatively or even more commonly post-operatively when you get a histology. And why is that? Because pre-operatively, now what you're seeing is a stone which is impacted the CHD. You just write down CHD and write Mersey syndrome query. But when you find a stone inside the CHD, the diagnosis is called cholecystectomy. They don't, or rather the definition or the definition of the fistula between the two is not easily discernible on a pre-operative investigation. So the classic description of the disease includes 4 components. Number 1, a closed parallel course of cystic duct and the CHD, an impacted stone, the cystic duct or the neck of the gallbladder, CHD obstruction secondary to external compression by the cystic duct stone and the surrounding inflammation, and a cystodocal fistula causing obstructive jaundice. So these are the 4 stages of a Mersey syndrome. Don't forget that, right? So that is basically a spectrum of disease that varies from extrinsic compression to a cystobiliary fistula. There are a number of classifications, but one which you can stick to is either Sessende's classification or a classification which is basically a fistula classification, much easier to remember. Type 1 is no fistula, type 2 to 4 fistula. Simple. Type 1A, presence of a cystic duct, 1B, obliteration of the cystic duct. See, no fistula at this point. But 2 to 4, now the fistula start, and type 2, you have less than 1/3 of the CBD diameter involved or CHD diameter involved. Type 3, 33 to 66%, that is 2/3, and type 4 is more than 2/3 of the whole of the diameter is involved. And this should be mentioned as CHD, rather be mentioned CBD, not my typo error. There's basically, I think, the error in the classification. Okay. Now, this is basically Mersey syndrome we're talking about. If you look at the Mersey syndrome and there is a comparison with the Sessende's or the McSherry classification, but just remember these classifications. And what do you find? You find a chronic cholecystitis, you find a compression. See this compression? Here compression, and then it is burrowing into the CHD. Burrows the CHD, right? So that is a cholecystoenteric fistula together with any other type of a Mersey syndrome. See, the stone has gone in. Type 2, all fistulas, right? So just remember, this is basically how it is classified. If you remember the stages, you'll remember the classification. So symptoms, acute cholecystitis, varying grades of obstructive jaundice, very easy. If you remember the classification, you can come up with the symptoms, right? No consistent unique clinical features for distinguishing from other types of acute cholecystitis. Nothing, except for the fact that this patient with acute cholecystitis may be having more than 4 mg/% of serum bilirubin. That could be the only thing. Imaging, as I said earlier, ultrasound and CT scan usually may or may not make the diagnosis. It's very difficult to see the fistula in these diagnoses. But MRCP or ERCP or even a PT, they can define the lesion anatomically prior to surgery. This is now the new addition. So if you have the MRCP or you go from below ERCP or you come from the hepatic PTC, in either 3 methods, you may, it is not again 100% diagnostic, you may be able to see for the fistula complication. So usually the diagnosis of Mersey syndrome is either mistaken for a simple cone bile duct stone that I was telling you about, a cholecystectomy, or is missed entirely on a preoperative work. Said earlier, the usual diagnosis is either peroperatively or postoperatively. So what is the treatment? The treatment is again slightly problematic. If you have stage 1, where it's only the adhesion, a slightly difficult laparoscopic cholecystectomy can be tried and you can be able to manage it. Because by that time, there is no fistula. Remember, stage 1, no fistula. But the adhesions between the Hartmann's and the CHD are already there. And that adhesion leads to a difficult dissection in the callous triangle. That is very important. So you got a difficult dissection in the callous triangle. Okay. Now, to enable you to do a better dissection, you may like to cannulate the CBD with an ERCP. So a CBD stenting can be done, or on the table you can do a T-tube insertion and then go ahead and do a further dissection, just to prevent injury to the CHD. Okay, so if you find a difficult callous dissection, you land up with an adhesion between the heart maze and the CHD, you can be sure of one thing, that you are dealing with a patient of Wilsey syndrome. And the moment you come up with a fistulous communication, that is the problem, or that is the stage 2 to 4 where the option of total cholecystectomy is no longer tenable. So what do you do in those cases? Just do a partial cholecystectomy with a stump closure and burning out the mucosa. Just leave that part which is attached to the CHD and just close it. There will be absolutely no problem in this patient. No problem. Just leave the Hartmann's pouch behind. Just leave it behind. Cauterize the inner lining and close it. The best option available. But if you have chosen to dissect out so that the fistula is now in front of you, then you have created a problem for yourself. So if you do a cholecystectomy in these patients, you would have to do a CBD repair, or else a much more formidable operation, and that is a bilioenteric anastomosis, especially in type 4 of a Wilsey syndrome. Why? Because more than 2/3 of the circumference has been involved in this and has undergone necrosis. So the moment you try to remove part of it, the CBD almost transects into 2. It becomes 2, the proximal part and the distal part. That is when you have the bilioenteric anastomosis, and that is why a safe bet is that you just open the Hartmann's pouch. You can remove the stone lying as a CHD through this. If possible, just close it and you'll be in a safe territory, and that's the best possible treatment of Wilsey syndrome. Okay, so don't try to dissect out the fistula. If you do, you have a problem there. See how it is. See the adhesion formed out here? Can you see the adhesion? That is the CHD, you see the adhesion. And the pressure, extrinsic pressure. So that is the initial stage of pressure. And now once this goes in, so this is the adhesion. Once this goes in, then that becomes a CHD. And usually you can also have a communication between, see what is this? This is the bowel, the duodenum. So you can also have a communication with the bowel. So you can have a cystodocal, that means bladder and the bile duct, or you can have a cystoenteric fistula. Is that clear? So you can have both the fistulas. You can either have fistula between the Hartmann's and the CHD, or you can have fistula between the fundus and the bowel. And which part of the bowel? The duodenum. Is that clear? So Wilsey syndrome stage 4 can give rise to a cystodocal fistula and give rise to cystoenteric fistula. Is that clear? Coming to the Bouvard syndrome. Bouvard syndrome is basically a syndrome. It's a rare syndrome. And here what has happened is that the gallbladder stone has migrated after pressure necrosis, just like in Wilsey. Here instead is migrated where? It has migrated to the duodenum, like for example stage 4 Wilsey, or a polycystogastric fistula. As a result of what? What happens? What happens is either a gastric obstruction or a gallstone ileus. Now in stage 4 Wilsey, if you have a fistula like this, what's going to happen? A stone moves here, goes distally into the small bowel and gets trapped where? Into the ileus. What we know is the condition as gallstone ileus. The gallstone ileus, that's what's happening out here. So the second method of gallstone ileus, so that's one method of gallstone ileus. The second method is duodenal or cystogastric fistula without actual inflammation, and that is the Bouvard syndrome, right? Gallstone ileus seen in a very small percentage, and if you see the incident gallstone ileus, that in itself is very rare, and out of this only 1 to 3% of this rare growth. That means out of 0.3, 1% or 0.3, that is 0.003%. So that is a very rare cause of ileus, right? Treatment again is simple, cholecystectomy, take down the fistula and repair the enteric defect, probably much easier than doing a repair of the biliary system rather than doing a repair. So if you have to have a choice between choledocal and cholenteric, I would select a cholenteric. Why? Because dealing with a cholenteric fistula is a much more easy proposition as compared to dealing with a choledocal fistula. Is that clear? Right. Now, prophylactic cholecystectomy, again a burning topic. Why should you do it or why shouldn't you do it? If you address the problem, one group says you should not do it. The reason, number 1, 1 to 2% chance of CBD injury. Number 2, increased incidence of CBD injury. Number 3, increased incidence of colonic cancer. That is well documented. And colon cancer of which part? The ascending colon and the transverse colon right side. And why is that? That is probably because the huge load of the bile salt, which are no longer being, or rather, the enterohepatic circulation is basically being blocked after cholecystectomy. So that is increased exposure of the colonic glucosa to a secondary bile after cholecystectomy. Number 3, duodenal gastric fistula. Number 4, diarrhea. So these are all side effects of a cholecystectomy. So prophylactic cholecystectomy, this patient did not have any complaint. Now is subjecting this patient to increased incidence of these diseases. In addition to this, 1 or 2% of CBD injury. But why should you do it? Why should you do it? Number 1, they say because acute cholecystitis can occur at any time with attendant complications. The reason number 1. Number 2, increased incidence of gallbladder cancer. Although the figure has been 0.5 to 1%, but these are Western figures. Don't stick to these figures in the Indian subpopulation. Why? Actual figures for India, they have probably a much higher incidence of carcinoma. So 1% is all right for Western figures. Probably in India, it is much higher than 1%. We don't have exact figures, right? The third reason why I want to do it is because of the increased lifespan. So if you have a diagnosis of gallbladder stone at the age of 20 years, you have a lifespan of 60 years. That's if we take an average of 80 years now. So those 50 to 70 years of lifespan, they're much higher chance of carcinoma gallbladder. So the younger the age group of diagnosis of gallstone disease, the more the need for going in for a prophylactic cholecystectomy. Why? Because that stone has got a longer life inside the patient. From 20 years, when it was diagnosed the first time, it can stay for the next 50 or 60 years if you don't remove it. So these are the reasons why it should be removed. So where is it indicated? Number 1, geographical susceptible area. In India, that translates into the Kashmir Valley and the Gangetic Belt. The whole of the Gangetic Belt. A patient with morbid conditions, diabetes, congenital hemolytic anemia, bariatric surgery. Patient factors like, for example, younger patient, I just not told you, life expectancy, anything more than 20 years. You're talking about 6 years in that patient. Multiparous female, first child before 25 years. Gallbladder factors. So these were the reasons for a prophylactic cholecystectomy indication. What are the gallbladder factors where you should go in for a prophylactic cholecystectomy? So the first one was the geographical reason why you should go in for prophylactic cholecystectomy. Then you had the patient morbid conditions. Then you had other patient factors which are not really morbid conditions, but factors which can always build up into increased incidence of carcinoma of the gallbladder. Then you got the gallbladder factors. Number 1, thick-walled gallbladder. And what do we mean by thick wall? Number 1, more than 3 millimeters of gallbladder wall thickness. And why? Because half of these are Xanthogranulomatous cholecystitis, which is a higher incidence of carcinoma gallbladder. The second reason, stone size more than 3 centimeters. And what has been documented? 10 times higher risk of carcinoma gallbladder. Right? High stone numbers. As what? The high stone based on the gallbladder volume. So that ratio, if you got a tightly packed gallbladder, as led to the volume of the gallbladder, these are patients where there is increased susceptibility of carcinoma of the gallbladder. Number 4, large sessile polyp, more than 1 centimeter size. Why? Because incidence of carcinoma gallbladder in these group of patients is almost 10%. Instead of the normal 1% or less, is 10%, 10 times. Anomalous pancreatico-biliary ductal union. If that union is defective, you may have an increased chance of gallbladder cancer. Porcelain gallbladder. Remember when we talked about carcinoma gallbladder? In the region of 5 to 10%. Mildew syndrome, we just not told you that. Biliary reflux after bilioenteric bypass, a condition seen in the post-gastrectomy patient. Chronically obliterated cystic duct. So these are all gallbladder factors which are working in favor of an increased incidence of carcinoma gallbladder, and that is why the need for prophylactic cholecystectomy in this group of patients. Right? Now coming to the third group, or rather the next group, and that is chronic calculous cholecystitis. We talk about the acute, we talk about the variants of acute. Now what about chronic calculous cholecystitis? Nothing much to tell you about this. This is a very small group, as far as the discussion is concerned. Recurrent pain with low-grade inflammation. 2/3 of the patient with gallbladder stones. 1/3 may still be there without stone. So 1/3 of them could be acalculous. Scarring and non-functioning gallbladder is a rule. That is a rule. Why? Because here you got a fibrotic and shrunken gallbladder. Often to an extent that's only about an inch or less. We have seen gallbladder less than an inch. And it's very difficult to say this is the gallbladder. Histopathologically, what do you find? Subepithelial and subserosal fibrosis with mononuclear cell infiltrate. The symptoms: recurrent biliary colic, nausea, vomiting, what we normally call the symptoms of dyspepsia, nausea, vomiting, bloating, belching in 50%, intolerance to fatty meals, all symptom complex which are peculiar or not exactly peculiar, which could be because of a chronic cholecystitis. It could be because of other reasons also, like for example, peptic ulcer disease, chronic pancreatitis, so on and so forth. So here also these symptoms are rather vague. They don't have anything specific to tell you that this patient has got a chronic cholecystitis. The diagnosis on ultrasound, if you find a shrunken gallbladder with a stone, the diagnosis is made for you. Wall thickness more than 3 millimeters, you're sure of the diagnosis. You find a non-function less than 50%, you're sure of the diagnosis. So these are some features which can hint at a diagnosis and give you reliability of more than 90%. What is the treatment? Simple. Just like acute cholecystitis, here laparoscopic cholecystectomy and open cholecystectomy. The only problem with chronic cholecystitis is that when you're doing a laparoscopy, you're doing an open cholecystectomy, the problem lies in dissection in the callous triangle. So much fibrosis, you can find often so much fibrosis, then trying to identify structure in callous triangle becomes difficult. So remember, when you're doing a lap chole or open cholecystectomy for chronic alveolar cholecystitis, be on a guard when you're dissecting in the callous triangle. Is that clear? Now, what are the complications? This is again a very, very important part. You look at the complications of laparoscopic cholecystectomy or standard cholecystectomy. The one and the foremost which comes to mind is CBD injury. You can have a collection in the Morrison's pouch, either bile or blood, in the postoperative period. And while we're on this topic, just let me tell you that 300 ml of collection in the Morrison's pouch on the first day and second day should not be taken with any alarm. Why? Because up to 300 ml collection can easily be absorbed by the body. So if you have a collection persisting beyond 48 hours, which is more than 300 ml, that should alert you to the fact that probably this patient has got something abnormal. So post-surgery, collection of 300 ml up to 48 hours can be taken as normal. Number 3, hemorrhage, which most commonly is because of a slip ligature over the cystic artery, number 1. Or number 2, an equally important cause is oozing from the gallbladder bed, from which you have to remove the gallbladder. And where does oozing come from? These are basically peripheral hepatic venues or the portal venues in these patients. So either hepatic or portal peripherally lying venous system, which are basically giving rise to this oozing. 4th, postoperative jaundice. We'll talk about that in a short while because these have to deal with CBD injury. Biliary peritonitis, again CBD injury, and bowel injury, usually in those cases where because of fibrosis or because of adhesions, the bowel, when it was being separated from the gallbladder, especially the fundus, or in the neck, 2 sides. Separation of the fundus, separation of the neck. When the separation was being done either in acute cholecystitis or chronic cholecystitis, there was an inadvertent injury to the bowel. That should have been recognized. You didn't recognize it, and that's why the patient came to you postoperatively. If you recognize it on the table, you can easily repair it. There's nothing very alarming about it. Injury can easily be repaired even laparoscopically. It's not a big deal. Okay. Now, what is the post-cholecystectomy syndrome? This is a term which is very commonly used now. Post-cholecystectomy syndrome. This is basically the most common cause is an overlooked extrabiliary disorder. Most common cause of a post-cholecystectomy syndrome. What does that mean? This basically means that when you carry out a laparoscopic cholecystectomy or an open cholecystectomy in a particular patient, where you found that the symptoms were probably because of gallbladder stone, those symptoms were not because of that. That means some extrabiliary cause was causing those symptoms which are misinterpreted by you or somebody else to be because of the gallbladder stones, and you did a cholecystectomy in that patient, missing out that this was probably because of the some other cause. And the most common cause is basically which one? It is intestinal. Most common intestinal, such as duodenogastric reflux, a peptic ulcer disease, esophagitis, irritable bowel syndrome, or mesenteric ischemia, diverticulitis, organic motor intestinal disorders, and so on and so forth. A whole lot of intestinal problems could have been the cause of those symptoms rather than the gallbladder stone. You could be having a pancreatic problem with this patient, acute or chronic pancreatitis as complications. You could be having an extra abdominal, like for example, psychiatric, neurological disorders, coronary artery disease, intercostal neuritis, wound neuroma, unexplained pain syndrome. So it is not only the abdomen we are talking about. Abdomen, we could be talking about intestinal pancreatic problem. or extra-abdominal. We could talking about number one, thoracic problems. We're talking about the integumental problem. That means the wall in the form of in the form of intercostal uveitis, or thoracic problem, like for example, a coronary problem, or it could well be in the mind of the patient, psychiatric problem, neurological disorder. So remember, whenever you want to carry out a cholecystectomy in a patient who has suspicious symptoms, which you could think that probably this patient does not have all the symptoms which could be ascribed to gallbladder stone. The most common among them is the patient comes to have a lot of belching. I have got this heartburn, and with these symptoms be over. Now, to be on the safe side, let me tell you, everybody, to be on the safe side, your answer should be, it could be partially relieved. We cannot give a guarantee of 100% relief. That is a very safe answer for you. So remember, next time, if a patient asks you, comes with the upper abdominal symptoms with a gallbladder stone for your cholecystectomy, and he or she believes that the moment surgery is done, all the symptoms will disappear. You, to be on the safe side, on your guard, should always tell the patient that probably there could be some remnant symptoms there. Because this could also be ascribed to other disease problems. So tell that to the patient. Post-operatively, you will be involved in post-cholecystitis, bile salt-induced diarrhea or gastritis. We talked about that. Morrison's pouch abscess, bile leak, which is a collection in the Morrison's pouch, generalized peritonitis, both because of accessory ducts, example, Luschka's duct, or a CBD injury. These two are very important. Very important. Either you manage to damage a duct of Luschka, or you have managed to miss it. You have not seen that duct, which is lying in the gallbladder bed. And you do a cholecystectomy, you come out, and that duct keeps on leaking bile in a very small fraction, keeps on leaking. Collection in the Morrison's pouch. Or it could even be a leak to some extent, give rise to generalized peritonitis. Or you probably missed a CBD injury that you're carrying out. Again, giving rise to what? A CBD leading to what? A collection as a bilioma, or vast enough to give rise to generalized peritonitis, or a calculi-related cause of post-cholecystectomy syndrome. And what is that calculi-related cause? Number one, you have left a slightly larger cystic duct, which now acts like a stump, and unfortunately, you missed a stone inside the stump. What is known as stump cholecystitis or stump cholecystectomy. Okay, or you could be having a more extensive part of the gallbladder left behind. Like example, you did a partial cholecystectomy, you missed a stone inside that, right? Or it could be a stone which is missed inside the CBD. Preoperatively, peroperatively, you're not able to diagnose it, and postoperatively, when you did an ultrasound, you found there was a stone in the CBD. At this point of time, let me tell you one very common problem, and that is when you're manipulating the gallbladder in doing a laparoscopic or manipulating doing an open cholecystectomy. If the patient has a slightly wider cystic duct, it is a known fact that a stone can dislodge from the gallbladder through the cystic duct into the CBD. So preoperatively, you search for the evidence of stone inside the gallbladder. There was none. Postoperatively, when this patient came back, he was severe pain. He got ultrasound done. You found there was a stone in the CBD. What has happened in this patient? Probably what has happened, there could be two things. One, it was missed out in the preoperative investigations. Yes, that is a very plausible cause. But another cause we should always remember is that your manipulation of the gallbladder probably shifted a small stone from the gallbladder into the CBD. So both the things are pertinent and both the things are plausible. Is that clear? So if you have a CBD stone manifesting itself in the post-operative period, don't say that this was because of preoperative diagnosis. In your mind, you know that probably this could have happened because of a manipulation of the CBD. It's all right to tell this patient that probably it was missed out preoperatively. He will believe you. He'll believe. But you should remember. And the third is a drop calculi. Go to the drop calculi. It is what known as spilled calculi. When you're removing the gallbladder, it burst out. It was torn, and the stones leaked into the Morrison's pouch, and from there could have migrated anywhere. And where do they normally migrate? Into the greater omentum. And they can give rise to what? They can always give rise to areas of abscess formation or areas of infection. So a retained or a spilled, I should call it spilled, a spilled calculi has its own complications in the form of sepsis in the postoperative period, not only the immediate postoperative, it could also be there in an extended postoperative period, let's say about 1 month, 1 year later. Why? Because these stones are probably lying where? Inside the Morrison's pouch, giving rise to subphrenic abscess, or it could well be inside the omentum. Another place where the calculi often missed out is in the port site. When you remove in a gallbladder, the gallbladder ruptured and a stone was left entangled in the port site where the wall between the layers, and often the patient comes to you with persistence of a port site infection. You find that there is a pus extruding to that, and you try to explore that particular area, and you find there's a large stone lying there, large or small stone, whatever. So remember, the port site, the omentum, the Morrison's area. The usual sites. It can, of course, it can migrate anywhere. But there are 3 usual sites where a spilled calculi can be found. And at all the 3 sites, it can give rise to infection. Biliary strictures, usually when you have damaged the right choledochal vessel. So where does it arise? The cystic artery. And that is why the dictum. The artery should be ligated where? Near to the gallbladder. The cystic duct should be ligated where? Nearer to the CBD. You all know that. You have to remember this, MBBS, MS, whatever. Cystic artery nearer to the gallbladder. And the reason is this. That is the reason. Why? Because when it comes out from the right hepatic artery, the first branch it gives out is a right choledochal artery. It then divides into the 2 branches supplying the gallbladder. Is that clear? So cystic artery, the first branch is right choledochal. And if you manage to ligate the cystic artery near to the right hepatic, you're going to damage this branch. And if you manage to damage this branch, this patient will come back to you 4, 5 or 6 years later with a biliary stricture. So damage to the right choledochal vessel is an important complication, and that is why cystic artery ligation near to the gallbladder. Don't forget this. So 2 proximal ligation of a cystic duct can again be a reason. Now what is happening? You are giving traction over the gallbladder, right? This is the gallbladder giving traction. This is cystic duct. When you give traction, it also tends what? It tends the wall of the CBD and the junction between CHG and CBD. It's going to tend it. And in your exuberance to ligate from its base, you also include a part of the wall of the CHG and CBD. So 2 proximal ligation. When you do that, once you release the pressure, what do you find? You find that part of the wall has been entrapped in the ligation. So don't tent it too much. And when you're trying to apply a ligature, the tenting should be removed before you tie the ligature. Remember that. So either you do a 2 proximal ligation of the cystic duct, or you do a 2 proximal ligation of the cystic artery. Both are damaging. So in one, it should be towards the artery should be ligated towards the gallbladder. And when in context cystic duct, where should you ligate it? You should leave a 2 to 3 millimeter stump. Remember that. Anything more than 5 millimeter would give rise to a stump cholecystitis. Remember that. So the part of the cystic duct which should be left behind is 2 to 3 millimeters, not more than that. Is that clear? Not less than that, not more than that. So safe level, if you want to have one cutoff level, 3 millimeters should be what you're looking at. So 2 to 3 millimeters left behind. You're not removing too much. You're not leaving too much. Is that clear? Ampullary causes, the patient has got a stenosis or dyskinesia of sphincter podi is again a cause for post-coagulatory syndrome. Right? Now, you have a CBD, you have managed to do a CBD injury. You did a very good laparoscopic cholecystectomy, very happy. I did a very good cholecystectomy, and you went home and you had a very nice sleep. Next day, you were looking for a cheerful patient, a talkative patient, and the moment you see that patient, you know something is wrong. Why? The patient is complaining. I have got severe pain in my abdomen, doctor. You feel his pulse, tachycardia. The patient looks ill. So if you have a persistent abnormal abdominal pain in the right hypochondrium in the postoperative period, you have to be sure that this patient does not have a biliary leak. What else points to a biliary leak in this patient? Clinically, that is number 1 indication. A patient with persistent pain without or beyond 12 hours, a patient who has got tachycardia a patient who's got a tender abdomen. Apart from that, if the patient you had put in a drain, there's leakage of bile from the drain side. Or the patient's got sign of biliary peritonitis. The whole of the abdomen is tender. It shouldn't be tender. The moment you apply pressure over the abdominal wall, it should be so pliable in a patient who does not have any leak. You're very happy about that abdomen. But here what's happening? The patient winces. So sign of a biliary peritonitis. Appearance of fever. The patient is febrile, although he doesn't have fever 102, 103 Fahrenheit. He has mild fever, right? Jaundice in this patient or increased liver function test. All of them would be pointing towards a biliary leak clinical, right? Radiologically, can you look at some reason why this is happening, or can you judge, or can you diagnose? An abdominal ultrasound is an absolutely useless investigation in this scenario. Why? It's just going to show liver collection. Dilatation of the gallbladder is not very easily seen. Why? Because by itself, an ultrasound is not a very good diagnostic criteria for a CBD. Any acute vascular lesion, again, cannot be seen on an ultrasound. So what else? You can do a CCT, slightly better. You can see a possible presence of focal intraperihepatic fluid collection that can also be shown on ultrasound. It tells you liver collection, it tells you about the hepatic collection, the Morrison's collection, tell you about the paracolic collection, it also tell you about the pelvic collection. It'll tell you, yes, there is some fluid out there, and you don't know whether that fluid is because of you washing that particular area or the fluid is there because of a biliary leak. And then you decide, let me look for 24 hours more, and I'll get it done tomorrow. And what do you find? You find the collection is still there. Again, you're on contrary, whether what is happening in this patient. So probably a CT may help you out slightly more. But among all these, the best investigation is the last investigation. Re-laparoscopy. Go back immediately. The moment you suspect some kind of a problem in this patient, immediately put a laparoscope back inside 24 hours down the line. Do that. That is the best investigation. It will tell you, it will show you bile, which shouldn't have been there. It's lying in the Morrison's pouch. It's lying in the parahepatic area. You'll find it basically bathing the whole of the small bowel and the pelvic area. So perhaps the best diagnosis could be made by a re-laparoscopy done within 24 hours. You don't want to do that, the patient is not ready for that, do an MRCP, which is the gold standard for complete morphological evaluation of biliary tree, as it offers detailed information about, number one, the integrity of the biliary tract. If you do it with a contrast study, they have told you about the gadaxitic acid, and that basically will tell you what? It will tell you about the leak also. You'll find that dye leaking from that particular site, tells you where it's leaking from. It allows detection of active bile leak by direct visualization of the contrast material, by demonstrating the anatomical site of the leak. So you've got only two options. So next time, forget about CT, forget about the USG. If you don't have recourse to MRCP, which we do have now, even at small centers, go and do an MRCP and do a re-laparoscopy. If not, then you can do an abdominal ultrasound or a CT. What about ERCP as a diagnostic ability? ERCP, it only goes to help you as a therapeutic that you just put in the ERCP. He may or may not be able to tell you about the cystic duct leak. Apart from that, a CBD, they will not be able to tell you about the right sectorial duct which is leaking from that particular area. So, an ERCP helps you by stenting that particular area and relieving pressure from the site where the damage has occurred. Is that clear? That's why I have not put this at this particular point. So, the best investigation could be a re-laparoscopy or a MRCP, an ERCP for stenting and passing beyond that particular area. The CBD injury, the best classification, although not the most optimal. The answer is best, not optimal. Why? It does not include the vascular component, right? So it could not demonstrate a significant association between the discrimination-specific injury pattern and the resection liver tissue. But just coming to this, you can divide this into two simple parts, 4 here, 4 here. This 4 part, the E part, is basically taken up from the Bismuth classification. This is also often known as the Strasberg Bismuth classification. It's on not only for PGs, it is also for the UGs. Don't believe that this is not what you should know. It's not beyond your course. You should know what this classification is. Why? For the simple reason that laparoscopic cholecystectomy is now become the gold standard. so commonly done, and the complications are coming fast and at a furious pace. Why? Because the moment you start learning it, your complication rate is not 1 to 2%. Your complication rate will well be 5 to 10%. So you have to know that. And type 1, basically, if you're looking at here, it is either leak proximally or distally. From where? Cystic duct or an accessory duct which you manage to injure in the gallbladder bed. So simple, proximal and distal leak. Here, you manage to ligate both of them, so there's no leak at all. But instead, what's going to happen? The moment you ligate this, what's going to happen? This was draining a particular segment of the liver. So that would get a back pressure effect, leading to an ultimate, some degree of jaundice and ultimate atrophy of that particular part of the liver. But because you know that you can sustain yourself with only 20% of the liver, this is not going to give you much problem. Why? This will just give rise to a degree of jaundice. But if it becomes infected, then you got trouble on your hand. So you can just have a back pressure effect with atrophy, or you can have an infection in the ligation which you ligated, that sectorial duct. This is basically a sectorial duct. Or you can have one ligated, the other open. So here what will you have? You have biliary bilioma, or you can have leaking, you have biliary peritonitis. So here both open, here both tight, and here the proximal open, or rather the proximal tight, the distal open. Is that clear? Very simple to remember. A, B, C. Now D is again not very regular, and here you manage to damage the CBD. Some problem either medially or laterally, and you've got a damage to the CBD. Is that clear? Now coming to the fifth type, and that is the bismuth classification, which is perhaps the most devastating complication which you can have in a patient where you manage to go in for a CBD problem, and that is the E1 and E2. Basically, you're talking about less than 2 centimeters or more than 2 centimeters. Which 2 centimeters we're talking about? We're talking from the porta. Porta, 2 centimeters, less or more. That gives you an idea where you can go ahead and do an anastomosis, or you can't do an easy anastomosis. Right? E3 basically damage up to the porta. That means you still have the confluence in front of you. You can still do an anastomosis. But if you even damage the confluence, then it becomes a E4. E3, that's E4. And along with this damage of CBD, any one of them, along with them, you have a ligation of both, then it becomes E5. Right? So this discrimination is important. Why? Because that gives you an idea what kind of repair you can do in this patient. But just remember one thing, vascular injury is not taken account in a Strasberg classification. And if you want to take the help of vascular injury, you can take a Stewart way or Hanover classification, where they have also taken note of the vascular classification. Is that clear? Now, coming to the management, and the principles are very, very important. You have a patient CBD injury, you'd be asked how you're going to manage it. The principles are simple. The first thing you need to know is that 25 to 30% of the bile duct injuries are recognized peroperatively. When you do it, you recognize that I have done something wrong. Either I've cut the CBD or I've done something else, right? So, but only 1/4. 3/4 are missed and they are diagnosed post-operatively. Principles are simple. Number one, diagnostic cum therapeutic ERCP to be done. Repeat re-laparoscopy, what I was telling you. So two things are very important. Send the patient for a stenting, and number two, do a repeat laparoscopy. Number three, drain everything, drainage of the collection, and number four, infection. 4 important points of management of BDI. Just note them down and memorize it. There's no other management which is as important as these 4 points. Number one, ERCP, stenting. Number two, re-laparoscopy. Number three, drain everything. And number four, control of all collection. And if you're doing a re-laparoscopy, the third becomes very easy. In a re-laparoscopy, you see where the collection is, aspirate it out, and you can put in a drain where it's required. You're going to put a drain in the right hypochondrium, put a drain in the pelvis. If you're required, you can put a drain in the left side. That is not going to kill the patient. But if you don't do it, under the impression that, look, what have I done? I've done a laparoscopy, the patient wanted only 3 holes, and how can I put these 3 drains? I can't put the drain here, here, and here. Don't even think about that. Go ahead and do it. Go ahead and do it. You'll be probably saving the patient. So just the belief that the patient has come to you for laparoscopy and now you have to put in these 3 or 4 drains, whichever is required, that should not be taken into account. You should go ahead and do it. Why? Because actually saving the patient. So these 4 things are very important: ERCP stenting, re-laparoscopy, and drainage of all collections under laparoscopic control. Is that clear? And then, of course, control all infections. This patient has to be shifted to high-end antibiotic. Why? You don't want any infection in this patient. If you have this, even the slightest infection, then the further repair becomes very difficult. Right? When you're repairing, the last principle comes into play, and that is you should ensure adequate vascularization of the end. That is very, very important. Right? Now, these are the 4 types: A, B, C, and D. These are good to be managed first, then we'll come to the E. Strasberg A, don't do anything, you don't need to do anything, just put in a stent and papillotomy. So whenever you're doing a stenting, always cut the papilla so that it becomes a wide drainage stent. So papillotomy, stent drainage, and antibiotic. The response rate is almost 100%. You don't require to do anything in these patients. 100% of the time, the patient is absolutely all right. Strasberg B, that basically talking about both ends ligated. I told you, a CBD stent with papillotomy with antibiotics, 90% response. The only thing could be that there is a back pressure effect. You find this to be swollen, you can go ahead and do a percutaneous transhepatic drainage. Right? Do a PDC. Transhepatic drainage, you can drain that particular segment. Right? If at all there is infection, you have to drain it as it is. Can you do a bilioenteric anastomosis? Very, very difficult. What do you have to anastomose? A very thin segment of sectoral duct. Can you anastomose? Very difficult. So forget about it. If you have recurrent cholangitis in this patient, if by chance this becomes a lingering infection, then you have to remove this segment. So it has to be a segment technique. So rarely do a stenting, a percutaneous drainage if required. Stenting would be enough with antibiotic drainage. If not enough, you can do an excision. You can try anastomosis, which is not going to help you, or you can do a segment technique. Type C, the type C. Same as B, spontaneous closure usually occurs out here. Spontaneous does occur. And here is slightly better than B. Why? Because it keeps on draining. And if you put in a drain, it keeps on coming out. So at least that part is not getting walled off in the segment. It is draining. The segment is draining. So the chance of having a bilioma in that particular segment, infection, is much less as compared to B. So in a way, C is better than B. Why? Because this is ligated and this is going to drain spontaneously, going to fibrose and then wall itself off. Strasberg D is an area which has to be recognized. It's not going to seal by itself. Probably putting a stent may, if it is a very small nick, it can probably heal by itself. So you can divide this as small depth without devascularization. That means both ends are vascularized. So that is basically you have recognized on the table. Just apply 2 or 3 sutures with a 5-0 absorber, put in a drain, put in a stent, and it's over. Don't require anything else. Whenever you put in a drain, always papillotomy. So I'm not going to mention papillotomy everywhere. So when I put in a stent, just remember papillotomy has to be done. So if the edges are vascular, laparoscopically, you can just put in 2 stitches or 3 stitches as required with a 5-0 absorber. But if you find that there's a larger defect where the vascularity is not very clear, you do a repair. But what happens? This patient is going to come back to you after 1 week with a leakage. So there the diagnosis is evident only at the end of first week. Why? Because at that time the drain is still there, it starts draining bile, it's not there. This patient develops what? This patient develops a biliary peritonitis. And then the only remedy available in that point of time would be a bilioenteric anastomosis. Is that clear? Now that brings us to the most problematic type of CBD injury which if you have done, that's the most devastating for the patient and for the surgeon itself, and that is Strasberg E, where there has been a complete damage to the CBD. What is important? Both the size and caliber of the bile duct. What have you managed to injure? What is the caliber of this? And how much size has been left behind? 2 things very important. So E1 would be the best one available, right? E4 would be the worst available. Why? Because you have to dissect this out, and then you have to do a photoenterostomy. That is the most problematic, most difficult kind of dissection. So size and caliber of the bile duct. Gradual, the infection. What does infection do? Infection leads to inflammation and fibrosis. So suppose the infection occurs in this scenario. you had more than 2 centimeters, and ultimately when you tried or you decide to go ahead and say, yes, now the infection is over, I would do a repair. What do you find? You find a very small segment remaining behind. Why? Infection leads to fibrosis, right? So gradual obliteration and damage of ducts from local inflammatory and sclerotic change. So the infection should be treated as early and as completely as possible. Time of the operation is an extremely important factor in the repair of the lesion, and that should be as early as possible. I'll just tell you what other factors take a role. And take care of infection and early identification of the lesion. They play a very important and key role. Per-operative recognition, you have diagnosed on the table, available expertise. Now, what should be done? You damage the CBD, what should be your response? Your response should be, if you have a hepatobiliary surgeon somewhere, ask him to come over or send the patient immediately to him. He will do a repair at the same time, which is probably difficult, but one of the best options available. Why? There's been no infection in this patient. Infection comes only later, after 48 hours, 72 hours. The repair has been done on the table itself at the index operation. You were doing a lap chole, you damaged, you immediately sent for the hepatobiliary surgeon, he came and repaired. The best outcome available, right? So a primary choledocojejunal anastomosis should be the rule. Expertise not available. What do? You put in a small tube in the area of the proximal most end, because often what happens is trying to identify that end becomes very difficult. Why? Because fibrosis occurs in that particular. So what has been recommended is just put in a very small feeding tube into the proximal end and bring it out and attach it to the skin, so that when repair, whichever hepatobiliary surgeon is going to do the repair, he can easily identify the proximal site. That is very, very important. And along with that, two very important things. The widest bore drains, two of them, one in the Merson's pouch and one in the right parahepatic. Remember that. Very important. 32 size, which is an adequate size drainage tube. One in the Morrison's, one in the parahepatic. What is that going to ensure? A proper evacuation of all collections. That's very important. If it by chance you didn't recognize it operatively and you came up with the diagnosis of a post-operative recognition of a damage, in that, immediately what should you do in that particular patient? Immediately you should put in a broad drain, a wide bore drain in spaces as mentioned above, and pose this patient for secondary repair after you have drained everything, after you have taken care of the infection. If the patient by chance was fortunate enough not to have a leak, but they didn't have a stricture, this patient will come to you after 2 months, 3 months, 4 months with a gradually drying serum bilirubin. In that case, you have to treat it just like a bismuth classification, right? Uninfected patient with fistula, the time period is very, very variable. 6 to 8 weeks, maybe probably late. Even later is probably more late. And then you have to decide when to operate. Next slide, I'll tell you. So what are the options available? A docojejunal anastomosis is the best option available, 1, 2, and 3. Anastomosis here and anastomosis here. But remember one thing, if you want to ensure a good vascularization, that is the most important point. Wherever you cut, suppose you want to anastomose out here, you have to always ensure that the vascularity of this segment is good enough to hold the anastomosis. Jejunum has a very good anastomosis, you know that. No problem with the jejunal part. The problem is only with this part. And that is why what has been advised is that as proximal as possible. So instead of just doing anastomosis here, because you thought that probably it's very easy to do it, easier than of course doing it here. No, you should do it slightly more proximally until you have bleeding or oozing from the cut end. Until you have that, you should keep on cutting. So ensure an adequate vascularization of the proximal choledocal segment. And often the anastomosis is better done in the anterior wall of the common hepatic near to the porta. That means somewhere here. Here E3, you have to do it. You don't have any segment remaining out here. You have to do it, right? If by chance you have E4, right? E4. What do you do in E4? This should be E4, not E5. E4. What do you do in E4? E4 basically you have to do a portoenterostomy, just like in the Casai's operation that we said in biliary atresia. So here, instead of anastomosing each of the hepatic duct, what do? You anastomose to the porta gliscens capsule and allow these two to open into the segment of the bowel. Right? Now, What do you do in this case? Suppose if you're damaged here, or let's say you're damaged here. Sorry. You have made this damage. Can you repair it over a T-tube? That is very, very controversial. And that is what I mentioned out here. Primary repair over the T-tube or Y-tube is the best best treatment or best surgical expertise available with a general surgeon. He always wants to do that. Always, every time. Everybody has done it. You have an injury, you would seek for a T-tube, and over the T-tube you would repair it. Now, there are proponents and there are opponents. There are a number of hematobiliary surgeons who say, don't do it. This patient will always have a biliary stricture. But at that point of time, probably having a biliary stricture at a later point of time would be slightly more beneficial instead of putting the patient on a prolonged biliary drainage and infection and everything, right? So end-to-end ductal anastomosis is a very controversial area. End-to-end ductal basically means I've managed to damage here. I showed you the other type and the D4 and the D type. So I managed damage here, I put on a T-tube and I repair over it. Not a very bad option. You can do it, right? Even when the maximum loss of length of bile duct is 4 centimeters, an early dehiscence of fistulization with late stenosis is the only problem in these patients. So what probably would happen is if you do a T-tube repair, what is going to happen is one of the stitches, one or two stitches may probably cut through, giving rise to a leakage for a certain time, but the patient will be all right, right? And even some experienced groups have mentioned very good long-term outcomes with this primary end-to-end ductal anastomosis. So we can't emphatically say, no, it should not be done. It's not that. What about anastomosing the duct to the duodenum? By doing a wide cauterization, even that they have said probably may lead to fistulization. But don't worry about that. If you have a damage to a duct in the region of the immediate supraduodenal part, go ahead and do a cauterization and anastomose it to the second part of the duodenum, just like you do it in the patient who has a choledocholithasis. You can do a choledochoduodenostomy. So here also similarly can be done. Now that brings to the last part of this cauterization, what is or the CBD injury, not to the last part of the lecture, still got a number of slides left. So timing of the CBD repair, when should you do it? The CDs reported worse outcomes performed within 6 weeks of injury. So we had mentioned 6 to 8 weeks. That does not hold too much water. Why? The timing of the repair was not an independent predictor of successful biliary repair. It's not only the timing. So what else is related to the timing? Number one, eradication of intraabdominal infection, complete preoperative cholangiogram, which you can do with MRCP, correct surgical technique, and repair by an experienced biliary surgeon. So remember one thing, it is not only the time which is important when you're going to repair it, along with the time, what else has to be considered is that the infection should have been completely eradicated. You should have a complete representation, anatomical representation of the part of the duct that you're trying to repair. You should use the correct surgical technique, and you should be an experienced biliary surgeon if you want to go ahead and try to attempt it. Is that clear? So the time is not one fixed time. It will depend upon all these, right? Now, cholecystosis, I think this is a very not a very common problem. You got basically conditions very chronic inflammatory along with hyperplasia of all tissue elements and could manifest in these 4 types. I think you can go ahead and read this. Cholestrosis, where you got a strawberry gallbladder, those yellow studded inside the mucosa, given rise to strawberry gallbladder mucosa. Glandularis proliferans, you can have the 4 types, polyp, you can have endomatosis, the intraluminal diverticulosis, stones and fistula. You can have a polyposis if it's more than 1 centimeter, always excise, because remember 1 centimeter cholecystectomy, 0.6 to 1 centimeter of follow-up of this patient. Remember that. Less than 0.6, don't worry, leave it. So polyps, less than 0.6, don't worry. 0.6 to 1, regular follow-up. More than 1, cholecystectomy. Is that clear? Don't forget that, underline it. Diverticulosis, black human stones, another method.